Welcome everybody to Daria for this week, the Drug and Alcohol Research and Innovation Active Learning Network. We're lucky enough to be joined today by Angela O'Connor, PhD, who's joining us all the way from Perth, where she says it's a bit cold, and I think was it 21 degrees over there, Angela?
That's right, Chris, I know.
Freezing, too cold. Angela is a nurse and midwife with postgraduate qualifications including Bachelor of Business, Postgraduate Social Science, Masters of Nursing, PhD, and with 10 years experience in alcohol and drug sector working with vulnerable women. And she is the clinical lead of the Women and Newborn service over in the North Metropolitan Health Service over in WA. So without any further ado, I'll hand over to Angela to talk about this very important topic. Thanks, Angela.
Thank you very much, Chris, and welcome everyone. Today, I'm just going to take you through basically methamphetamine use in pregnancy, what our service does, and then at the end, I'm going to talk about my PhD outcomes because it was measuring maternal and fetal outcomes post-exposure to methamphetamine in pregnancy. Before I get started, I'd like to take this opportunity to acknowledge that I'm hosting this meeting on Aboriginal land, the land of the Whadjuk people of the Noongar Nation, and pay my respects to elders past, present, and emerging, and also extend to your elders from New South Wales. So as a way of an introduction, just to kind of give you a little bit of context from where we're operating from, is that over here, we're known as WANDS, the Women and Newborn Drug and Alcohol Service. We're considered the largest drug and alcohol service here, predominantly because we do a statewide service. Women get referred and transferred from all over the state down for risky drug and alcohol use. I'm not talking about just a little few smoking of cones, etc. I'm talking about significant drug use, and if the pregnancy starts getting compromised, they refer them back down to us in Perth. We have a multidisciplinary team, which is midwifery led, which is really fantastic. So we coordinate the whole service. We have doctors, we've got an addiction specialist, we've got social workers, we have psychological medicine in our team, and then we bring in anyone else that we need as we go forward. We actually do an outreach service to the prison. So we go out to the prison usually once a month for any pregnant woman that's incarcerated. And then we actually organize for them to come into the hospital for their scans, etc. We operate on the principles of being trauma informed. We have that practice that underpins our service delivery, and we utilize harm minimization and harm reduction in the context. So just to note that the women and infants that we look after usually have complex clinical and psychosocial issues. And finally, I want to introduce you to my PhD results. Excuse me, I did a mixed method prospective cohort study. So just here, I just thought I'd give you a little bit of a picture for those of you who haven't been to see King Edward Memorial Hospital. It's 100 years old, and we do look after women that get transferred into us from all over the state. What we do, the aims of the service for WANDS is that we love to work in partnership with people. We don't believe in anything in isolation can help. We need to kind of build a community around families and pregnant women that use drug and alcohol in pregnancy. We link in to community supports, NGOs, Homeless Connect, engagement of people to help us to achieve the outcomes for pregnant women and their families is critical to the success. So we spend a lot of time building capacity and working collaboratively, both within our hospital system and out in the community. And as I said earlier, we also provide a service into the prison system. Our philosophy is we keep our women in for 5 days postnatal stay, and which is a really good thing for us considering the pressures that we have daily on bed numbers and getting people in and out. But we believe that 5 days, it enables the women to kind of start that bonding. We can do a lot of education. We can assess them during that 5-day stay also, because particularly if they're continuing to use in that period of time. We set up a postnatal follow-up clinic a few years ago, and we see our infants usually up to 3 months, and then we discharge them into the community. However, our social worker members of our team, they will see and follow up the women if they want to for 6 months, and psych med department on our team, they will give access to follow up for 12 months. What we do, our aim is we discuss parenting safety and AOD use. We talk about infant feeding, breastfeeding as opposed and formula feeding, and we like to give ongoing support to the women. So a little bit of background, of course, for us, the topic for today is methamphetamine use, but I just want to kind of preface that we can't just, focus just on one drug, because a lot of the time the women will use polysubstance use in pregnancy. But noting that methamphetamine is a potent neurostimulant, there's quite a lot of stuff written out there in the field about methamphetamine. And collectively, they're known as a group like the ATS. Amphetamine and methamphetamine use in Australia continues to be a significant public health concern in pregnancy. Western Australia predominantly has a high uptake and usage of methamphetamine, and it's across the whole state. So from our perspective, understanding the effects of this prenatal exposure and having supportive environments to respond and assist families is really the long-term outcome, and the effects is critical for us as a team. Just as an overview, and I'm not going to go through all that, I kind of put it down in for methamphetamine and the ATS and other pharmaceuticals. And when we refer to it, we're talking about powder form, we're talking about base level, and we're also talking about crystal meth, ice. There's lots of acronyms that people use when we refer to that. But just of significance is the purity of methamphetamine is about 80%. So, and usually it's smoked or injected. So our women report that they generally tend to either smoke or ingest, or they snort it. They also smoke quite a lot. We have about 88 to 90% of our women in our service who smoke cigarettes. And then they also combine some cannabis with that as well. And then they will use benzos, which we generally kind of find we use when they come in and they're detoxing. We will give them some, but on top of that, they actually use quite a lot that probably are not prescribed. A good strength of methamphetamine lasts, as we all know, about 12 to 24 hours, but the effects can last for up to 30 hours. It's widely available here in WA, and the price varies, but for the purpose of today's session, they can usually buy it between $50 to $80 a point, which is equal to 1/10 of a gram. And dexamphetamine tablets, they're readily available also, and they cost about $2 to $5 per tablet. I just kind of put this up for people so we kind of understand when we're talking about methamphetamine, it's got that rush, crash, run cycle. So the women will go on their usage phase, they don't sleep, they don't eat, they can become paranoid, they've got a high level of arousal. And we don't generally tend to see them at this stage because they're quite busy. So that'll be kind of like day 1 to day 2. When they have some money, they go out and they will use. In the early withdrawal phase, we have a clear philosophy in our service and in the hospital that we want to encourage access to care. So we have an open door policy so that if the women kind of feel that the baby's not moving, they're not feeling quite right, we actually invite them in to come in and we listen to the baby and we kind of try and engage with them. At this phase, of course, they can be aggressive in their mood, and their mood swings can be quite labile. They tend to be irritable. They certainly don't like us asking questions because they get grumpy with us, and they're often having cravings. And then you'll find that they go using continuously. So that's that kind of cycle that they find themselves in. It's also important to note that all drug users are not the same, and particularly amongst pregnant women, we find the following patterns. So some women continue to use during pregnancy, and they may be able to reduce, certainly at different times. And particularly when child protection are in their lives, there's a big pressure on them to do urine drug screening, attend meetings with them. So we have that little bit of variation. Sometimes they're detoxing from drugs completely, and we have had quite a few success stories when women have come off and they've actually stayed off during their pregnancy and the early postnatal period. Some women will be using, but they're out there and they use, they'll be on heroin, they'll be, whatever they're taking from an opiate perspective. And so we will actually help them to go on to the opiate replacement. So usually methadone or Subutex while they're pregnant, and they come in and we manage that throughout their pregnancy. I just kind of put a little bit of data here. I haven't got the 2022 data, but we probably get about between 400 and 500 referrals per year. And sometimes we end up between 240 to 300 deliveries that birth with us in a team, because particularly sometimes the women in prison, when they get out, they'll go back to communities or they may go elsewhere. And they generally then, some of them will come back into us, but we lose some as well as we go along. I just like to put this up because it kind of gives us an overview that we can't look at drug use just in isolation, because our women are really vulnerable, the cohort that we look after. And when you put substance use in the mix, often these women are exposed to family and domestic violence. We've had high rates of that. They're often on the poverty line. They've got no access to housing. Transport is a big issue for them. Getting them to clinic, we do ask an awful lot of them. We do try where possible to give them access to transport. We give them vouchers. We try and make it as easy as possible for them to access our antenatal care. We often find that there's the intergenerational drug and alcohol use, which kind of, impacts on the pregnancy, particularly in our Aboriginal families from that family of origin. The women often are exposed to quite a lot of legal issues. Some of them find themselves in and out of pregnancy. Often their overall general health is not very good, and they're increase in their stress levels, and particularly if they're put into prison, it's like who looks after all the other children. They've got the stress of child protection and family support because they have to attend quite a lot of meetings in urine drug screening. They also had to experience quite a lot of loss because a lot of our babies and children get removed and placed into out-of-home care, and also they have that intergenerational loss also. And also I put policy on mothering up here because I always think it's a good thing for us to challenge what our policy on mothering looks like, and particularly in the context of when you're dealing with vulnerable women, because they don't meet the, I suppose, the stereotypical view of what mothering is, and because there's a huge amount of stigma attached to drug use in pregnancy. We also know that mental health and AOD issues go hand in hand. And I just kind of thought as an introduction into this, it's like which comes first, the chicken or the egg. What we generally see in our service is that we definitely cannot take these away. Often women have significant mental health issues, and as a result, they use drug and alcohol, and underpinning all of that, of course, is that they've got high levels of trauma and chronic trauma. which brings me to this, this chronic trauma kind of background from a perinatal mental health and drug and alcohol perspective. What we generally find is that the women with chronic trauma and the drug and alcohol, it affects, as we all know, that the brain and the frontal lobe of the brain, and their memory and their response, they can become quite emotionally dysregulated. They sometimes have quite impulsive behaviors. They can be highly suspicious, particularly until they form that relationship with us as a team, and they're hypervigilant, which sometimes leads to a bit of their aggressive kind of presentation. They can be non-compliant about, they don't kind of prioritize the fact that they may need antenatal care and they may not come. So we kind of work really hard from our multidisciplinary team to make it easy as possible to get in to see us. And that trauma-informed practice really helps to kind of maybe reduce some of that suspiciousness with them. And they often they can have very ineffective coping skills. And some of our women with this whole picture can be quite manipulative of the team. And particularly when you're dealing with some of the personality disordered people as well that have that psychological background. It's probably good, I just put this in really as a little bit of break about why do women use drugs, because of that high level often of the stigma, associated with it. And I guess if we kind of think about that underlying trauma of why they use it, some women tell us that they use it because it makes them feel good and they want to experiment. So there's a very wide range of reasons that they do use, but trauma, particularly the underlying trauma, is a big factor for our women, and particularly that intergenerational with our Aboriginal families and our Call families. We find that trauma underpins quite a lot of the reason why they use. A little bit about methamphetamine and I guess where we are today. Just for your information, there was one really large study done in America known as the IDEAL study, and that was done in 2010. And it is probably the most detailed data available. There has been some studies done here in Australia, South Africa, in Europe as well. But we kind of focus on this larger IDEAL study that they ran across the USA. And they ended up having 191 women in their survey. 50% of them use methamphetamine, and they also found that they had 50% with meth use had less than a high school education. 50% reported having a partner, and the average age in that group was 26 years of age. We do know also that data is limited, and also we have limited data available in Australia. So when it came to me, when I've been working in this service and noticing that our major drug of choice for the women coming into our service was methamphetamine, I really wanted to kind of explore and see what the effects of methamphetamine, is it different to other drugs that people use. What we do know from an obstetric perspective is that because the psychostimulant of methamphetamine, it increases obviously risk factors in pregnancy. So maternal hypertension, tachycardia, there's a higher risk of them going into preterm labor. There's higher risk of them having placental abruptions and hemorrhages and spontaneous abortions. We've had issues with cardiac issues. We've had stroke as a result of the effects of methamphetamine, and the greater issues of obstetric complications resulting in maternal death. We do know that our women, because of that frontal lobe perspective, and particularly because the women don't just, fall pregnant and start using drugs, they've been using drugs for quite a long time. And it does often, we find that it affects their memory and the processing of information and their attention issues. And it really does affect that executive functioning. We as a team try to be really, I suppose, proactive in this space. We know that we try and give the women very small amounts of information in small blocks and frequent. We invite them in, like normally in an antenatal clinic, they'll come at 20 weeks and then we don't see them, there's 28 weeks, 32. In our service, we bring the women in quite frequently and sometimes weekly. And we send them text messages and we follow up. That's 24 hours before, and then we do it on the day of clinic as well. So we try and kind of engage them at every aspect where we can. We do know that there's some really significant barriers for treatment. Women are exposed, as I said already, to high incidence of family and domestic violence. They often have very unsupportive partners. They often are forced into kind of unsafe sexual encounters, and they feel quite a huge amount of shame. There's also an underpinning thing that there's always fear of losing their children, and if they engage with a service around drug and alcohol issues, that will actually link in for their babies being removed. And we've done a huge amount of work in this area, particularly with our Aboriginal families. We found a few years ago that we had a lot of Aboriginal women disengaging, and so we sat with the elders of groups, and we kind of wanted to know where the women were going, because we knew that they were, probably really risky. They needed some kind of assistance, and so as a result of that, we kind of had a look with our child protection and how we could make this better and more open. And we started getting our women back in, but it is a real issue for them. They're also very fearful of judgmental treatment with the team and that hyper vigilance and suspicion that they're going to be judged. They often have depression and low self-esteem, as I've said earlier, and some women believe that they can handle the problem without any treatment, and they don't see the reason to come into a specialist drug and alcohol service. I've kind of put this up there just to kind of show you over the years and the numbers, and our numbers have been increasing over time. So I finished that one in 2018, but our numbers have been increasing with the amount of infants being removed, and our Aboriginal group cohort, there's higher numbers of their infants removed, and sometimes from birth. From a service perspective, what we see from a treatment for women in this cohort is that really a service that's trauma informed, and the team takes that on. We get women in to our clinics. We don't go out. It's not kind of in the remit because we're a tertiary hospital, but we would love to be able to go out into the community and visit them. We know that prevention efforts must be the focus from the women's drug use. We take the focus away initially, and we want to understand them, where they're at and what their related health and social problems are. And when we start looking at some of those issues, then we start focusing then on the amount of drugs that they use. But it's not always about you're using drugs, because they've actually consented to come to a drug and alcohol service. So it's a given that they're using. And our responsibility, we see as caregivers, is to provide that network of supports that directly address their contributing factors. We know that, and we note in our service, that AOD use has a common language. We know that we're dealing with vulnerable women and families with co-occurring complex conditions, and we have to be really sensitive to this as we go through. We also know that we have the coordinated service provision with a multidisciplinary team, and that interagency approach is crucial for success and getting people to come and improve the outcomes, really, because that's a big factor for us, is that the earlier we get pregnant women in, we know the better outcomes we have for the baby. And we really foster any partnership with the family and provision of service that's culturally appropriate, regardless of whether Aboriginal or called. And we know that we really need to focus in on more developmentally appropriate services, enhancing safety and improving everything from the perinatal mental health outcomes. I'm not going to kind of focus too much, but really the big takeaway point here is that in pregnancy, from a harm reduction thing, is to help reduce drug and alcohol use from that really risky levels down to, you know, as much as we can, see if the women can reduce their drug use. We are focusing on smoking because we know that some of the smoking complications are equally as risky. So we do that harm minimization and harm reduction approach in that context when we're speaking to the women and engaging them. What we do know is that, of course, any drug and alcohol use impacts the parenting of an infant. And substance use and addiction are complex, hard to solve problems. We fully appreciate that. And when a woman is pregnant or parenting, the child is undeniably part of that equation, and we never separate both of them. We kind of take it in that context of taking them on a journey and improving the outcome. And regardless if that means that the baby's been removed and placed into out-of-home care, we still work with that family to make sure that they have access to that child going forward. And this provides a significant motivation for some of our women to change and reduce their drug use. And from our perspective, from a service perspective, is that access to care is crucial. It's the key. And we also know the potential negative effect for children from that exposure from a safety aspect and also from impaired dynamics with the mother. We also recognize that not one drug is used, that often women will use polysubstance use, and we have to know what those risk factors are and the impacts on parenting moving forward. We, as a service, recognize that we have challenges in no one service is correct and fully funded. We have funding issues. We have limited rehab options and availability for spaces. Even when women are ready to go into rehab, sometimes it's tricky to get those spots. We lack sometimes refuges that will take women and children, so we're trying to increase that and put some pressure on policy and government. Sometimes we lack that coordinated service because we operate in little silos over here. I'm not sure if it's the same in New South Wales. Often the women, the challenges is transport. You know, we're asking them to get in. They have no means of getting there. They often don't have any money to get on the train. So it's a constant kind of risk for us. We have women and children in prison system. And the investment in early childhood programs sometimes are lacking, or when we do get funding, it gets removed after a cycle. I just thought I'd put a few slides up because people often ask us about breastfeeding and drug use from a service perspective. And we always take the thing is that if women want to breastfeed, we acknowledge that if they're really using quite an awful significant amount and they're also using quite a significant amount of benzodiazepine, we do actually encourage them not to breastfeed, but we can't make them not breastfeed. So we do the best in the safety environment. And we start that planning early on when we meet them. And that really is the key. Are you planning on breastfeeding your baby? And, you know, from best practice and whatever it is to say that if women want to breastfeed, we should encourage it, even if it's for a short period of time. We know that drug and alcohol use actually limits the production of breast milk, and we see that all the time. And I'll show you a slide where the women start off breastfeeding and slowly but surely their milk supply reduces. And we take, our team takes the philosophy is that we don't stimulate we don't give them any drugs to stimulate milk. We allow Mother Nature to do her course. And if it's not safe to breastfeed, we actually will challenge the women on that. It's certainly not safe to use inhalants while breastfeeding, and many drugs, such as methamphetamine, can be cut with other substances because the purity may not be that great, and it can cause harm when that transference over to the baby. So we do an awful lot of safety planning in between antenatal and all the way through to the postnatal period. So we advise the women about drug and alcohol use and the risks. We ask them to withhold breastfeeding temporarily, especially if they're using, and we do ask them sometimes to avoid feeding at maximum milk concentration. So, and these are just that, the amount of drug ingested. There's been a lot of research done in this field from Anbar 2 over here in WA, and we've looked at kind of milk concentration. Hasn't been done for a while, but we do know that transfer is really critical. And the age of the infant is also really important when we're thinking of that infant exposure. So a lot of our women start off breastfeeding. We have between 45% of them in our service will start off breastfeeding, and slowly but surely then their supply starts reducing. And we see them up till 5 days in hospital where they're establishing their breastfeeding. And then we see often that they start kind of giving baby formula because their supply is reducing. And then we see them up to 3 months for those who come back to us. And we sometimes don't know if they're still breastfeeding when we discharge them. What we do know is that drug and alcohol use have a very low molecular weight and lipid solubility, so it makes it really easy to cross into breast milk. We don't know a lot, there's not a lot known about the effects on the infant, but we weigh up that risk versus benefit. And we do know, as I said to you, the reduction of maternal prolactin levels, so it does decrease milk production. What we watch for is sedation, and we teach the women if the baby is sleepy, poor feeding and thriving, that, really kind of we're honing in onto that safety aspect with breastfeeding. We talk very much about alcohol and feeding, and we certainly tell them that our advice would be not to drink, not to feed, if they're going to be drinking. And if they continue to, if they're going to drink, that we ask them to wait 2 hours for every standard drink and wait 4 hours if they take 2 drinks, for example. But if they're planning on going out for a night, we ask them who their safety person is and get someone to look after that baby to express before they go. And then if they're feeling a little bit drunk or whatever, that they avoid breastfeeding. And if they have, milk expressed and they've been drinking, that they discard it. So it's all around that safety aspect that we do. We know that breastfeeding and smoking is really also a consideration that we also address with the women. And we also acknowledge that breastfeeding is the best way to feed babies for that mother-baby bonding. And it's better to breastfeed and smoke than not to breastfeed at all. But we also advise them about nicotine passing rapidly into the breast milk and affects supply. So we offer women nicotine replacement patches. Some of them take it up during pregnancy. And we also talk to them about passive smoking and also other family members in the room, and also the health impacts of it. So we try and do as much harm minimization and harm reduction as possible as we go through. And then that safety plan about no co-sleeping. We also, that whole thing about getting a safe person. If the partner is using, we address those issues. We also talk and show them how to make formula up, and we also talk to them about drugs being available around the house and storage of drugs and medications. And then we acknowledge that, it can be expensive to buy formula, and do they have enough money? So our social work team will often help them out in that. And if they do choose to feed, we actually go through all of the aspects of infant feeding and formula. We also know that some people also ask us about hepatitis C, and we know that there are no confirmed reports of hep C transmission from mother to baby by breast milk, and we have written a paper from our service in this field. The big factor for us is that we do know there is a bit of a risk if women start having cracked and bleeding nipples. So we ask them not to rest their nipples, and we discard the milk at that stage. But overarchingly, women with hepatitis C, we don't discourage them from feeding. So our neonatal outcomes, just that to note that drug of abuse, the same thing, will pass across the placenta to the fetus. There is high risks of that prolonged premature rupture of membranes, intrauterine growth restriction, fetal distress, and neurodevelopment impacts on the baby. Look, we do an awful lot of education around neonatal abstinence syndrome, and if the women are using, what we see predominantly, particularly with methamphetamine use, it's very different from a woman who's coming in with that opiate withdrawal. We know that NAS term babies are more likely to be affected than preterm babies, but we don't know the incidence. What we do know, particularly because we have the high incidence of meth use, is that our babies we find on the postnatal period are that these babies are drowsy. They're slow to feed. Their sucking reflex is a bit not developed, and then they start losing weight, as opposed to our lovely big term baby whose mom's been on either, and they come in and we see that early signs of withdrawal very early on, and these babies want to tell us that they're not happy, they're withdrawing. We send them down to our special care nursery and they're put on morphine to take the edge off of their withdrawal. We know that Finnegan's is probably not the best scoring tool for babies that are withdrawing, particularly from methamphetamine, because we don't see an awful lot of it. But Finnegan's is the best score that we have at the moment. So we do use that and we put it in for the first 5 days whilst they're in hospital. And then if babies do start withdrawing, we send them down to our special care nursery for treatment. Parents often are very anxious in this stage, and we kind of acknowledge that because they're feeling really guilty that their baby is going through this withdrawal and that they end up having to be medicated at some times, not for our methamphetamine babies, of course, but for our opiate replacement babies. And NAS, neonatal abstinence syndrome, also affects infant feeding. So we sometimes don't do, I did an audit quickly on our staff and when we're out on the wards and how good we are at doing it. So we start off really well and we try and do this withdrawal NAS scoring for the first 5 days. So I'd like to take you through my research at this stage for us for my PhD and methamphetamine. So as I said earlier, it was a mixed method research design. I did a qualitative and quantitative. I wanted to not only look at the infants, but I also wanted to look at the maternal outcomes. And I looked at the effects of children being removed and placed into out-of-home care. So I did some interviews with 20 women that agreed to take part in that. And then from the baby perspective, I really wanted to hone in as methamphetamine as a drug. I did an ages and stages developmental check on the infants at 3 to 4 months, and again at 8 months. I did general movement videos on the babies just to see what general movements looked like, because that was the first time that we've done that in our service to look at that, and that was based on PREX, and I'll take you through this. At 12 months, we invited all the children back and we did a Griffiths developmental check to kind of get an overarching view in that period of time and what the effects of it was. And that really kind of formed the basis of what I was trying to do. Noting, of course, that amphetamine and methamphetamine use was really kind of the uptake of it was significant here in Western Australia, and we still have it. I think Melbourne took over for a short period of time, being the greatest uptake, but it's back to WA again. I really wanted to understand the effects of that prenatal exposure. I wanted to look at our guidelines because Finnegan's not being the best tool. What could we do differently in that? And wanted to kind of look at, could I kind of push for a longer term approach for following these infants up in the long term? I just wanted to put this in here because, you know, addiction, noting we always say that it's a chronic disease with periods of relapse and remission, and that the average course of drug use is around 27 years. And sometimes we do get some really good outcomes, and 58% of people do achieve lasting recovery. But this is all of the lovely areas of the brain, like I was talking about memory and reasoning and functioning and their drive. And this is where we find that we're trying to help women and families along this journey. In my study, I ended up having 220 women that actually enrolled in the study. I had 115 that consented to participate, but then 3 of the women withdrew, and they were women that had been released from the prison system, and I just couldn't follow them up, and some of them just withdrew. I had 112 women that remained in the study, but out of that, we ended up having 2 fetal deaths in utero and 1 stillbirth. And then sadly, we had 1 SIDS at about, I think it was about 6 to 8 weeks post birth. So resulted in 110 infants with 1 set of twins, and 109 infants came back for follow-up. So, you know, there was an awful lot of work and support put into getting them. The ages and stages was completed by 82% of the population of 4 months and 69% at 12 months. And then 60% returned for the Griffiths developmental scale. So, and overarchingly, I ended up having 58% of the population completing all 3 assessments. The maternal demographics, which when I started and I was talking about the ideal study, the mean age for the women were 29.6 years of age, and they had 4 previous children. Aboriginal population was overrepresented, and they were overrepresented in the prison system, 53% as opposed to 44% Caucasian and 3% other. Quite high incidence of homelessness and trying to get people into refuges, and 12% were in prison. 88% of them smoked tobacco, 70% used 1.5 grams of methamphetamine, mostly intravenously. They drank, they used polysubstance. They had high levels of family domestic violence and mental health issues, and 93% of them were unemployed. So this is just in graphic from the pregnancy trimesters, 98.21% used in the first trimester, and then slowly but surely, as we kind of started going through, some of them started reducing, but not really to any significant amount. Mostly injected, as I said, and then the next largest ones was smoked, and then some of them did both. Interesting for our maternal complications was Hep C, of course. We would expect that. Pregnancy-induced hypertension. We had renal issues, cardiac issues from injecting. We had some really nasty infections from injecting drug use without safety and the sharing of needles. Cholestasis was quite common, and we had threatened preterm labor. So, and also anemia, and we kind of did quite a lot of iron infusions throughout their pregnancy to keep them topped up. So the outcome for us was getting the woman in the best place as possible to improve the outcomes. So Hep C was quite high in the population. We tend to see that we do have quite a lot of women that have hepatitis C in our group, normally outside of research. This just kind of give you an overview of the amount of iron infusions that we do, and we follow up their bloods quite significantly. We do focus on contraception quite a lot, believe it or not, and we try and kind of get as much contraception education and before the women leave, we try very hard so that they won't be coming back all the time, and give their bodies a chance to recover from birth. Our neonatal characteristics here, you can see that 47.8% of the babies were girls and 54% were male. Our mean NAS score was only 2.9, and that's where I'm saying that, you know, our Finnegans may not be the best tool to use when we're talking about methamphetamine, because the babies are sleepy, because mom has generally kind of done a bit of a binge before she comes in to deliver. We do induce quite a lot of the women around 37, 38 weeks, because we find that the growth starts going off. We had 24.5% of them had preterm, and we had 30.3% of our population that babies were removed. But overarchingly, 58% of them had child protection remained in their on the path, on the journey. 41% of our babies ended up going into special care nursery, and they were often due to, failure to thrive, some breathing, some infection rates. And then you can see here the parameters from the head circumference and the weights. So we did an ages and stages developmental assessment, and just to give you, excuse me, a bit of an overview. We had a good return rate from a research perspective. I was really happy with that. And we had 58% of the babies came back for their Griffiths developmental assessment at 12 months. I'm not sure if you're familiar with it, but we do a general quotient from a developmental Griffiths assessment, and we found that the mean GQ score was 92.7, which was really significantly lower. And I had a not really truly representative of a great comparison, but at Fiona Stanley, they had a historical cohort of infants that had some similar levels of risk, not all drug and alcohol, but I needed something to compare with, and that was the best group. So we found that then that when compared to that cohort, they had a median general quotient of 113. So we saw that there was a weak correlation between the 12 months ages and stages and the GQ. So that was quite interesting, and that just kind of gives you a different picture. We found, though, that some of the babies were quite fat. 10 of the 64 babies kind of placed in the obese range, which was really interesting for me. And these are just, I'll make these available for you if you want to have a look. They're just kind of pictorial levels from the Griffiths. What I do want to talk to you about was that this was really novel for us because we looked at general movements from an infant perspective. So I did a video in the first 5 days for general movements, and then I repeated it again at 3 months. And overarchingly, I found this just kind of the tool that I used. I'm not sure if you're familiar with Preck's general movements, but when we did the videos, we set them up. They were all consistent. We had one of our physiotherapists who has trained in general movements using the Preck's general movement scale. And so we had her reviewing them, plus our neonatologist and myself. And you can see here that at the first ones, we had 21.4% of them had normal assessments, which we had 44.6 had poor repertoire movements. And this may not mean anything to you, but what we were looking for was, are these infants at risk of developing cerebral palsy? Because that's what the tool is used for. Or is there any early indicators to us that we need to be following them up more closely? And we didn't find any significant correlation between that motor optimality scores and our Griffith scores at 12 months. But we did find that we did refer a few babies for developmental assessment. 6 of our babies went on. 1 baby did end up with cerebral palsy, which was really interesting. The last few slides here I just have are, parental substance use affects the whole family, and it affects these children across the lifespan. And I only concentrated on the first 12 months, and we know that we really need to follow these children up into the long term. We also know that these babies, particularly from methamphetamine, are drowsy in the first few months. They often have high levels of anxiety and depression. They have speech problems. There is a Swedish study showed that females exposed prenatally were significantly shorter and lighter than their males. They often have poor concentration and ADHD as they get older. They often have low birth weight and trouble controlling their thoughts. And this is across some of the research research that I put together. We really need to focus on programs that has a dual focus on women and their children going forward. We need to focus on the social determinants of health where possible and understand AOD in that context. And we really need to look at parents regaining custody of their children, because these women, we found, they tend to kind of get pregnant, and their philosophy underpinning that is that at some stage we'll allow them to keep a baby and bring it home. But I guess if we have that whole supports around that, maybe we can improve that outcome. And not to kind of take away from the fact of the complexity in this field that, you know, babies, the foundations of their mental health begins in infancy. And our research outlines infant trauma, and the role of attachment is really crucial in this space. I want to just kind of put together some of our cautions and limitations, because I suppose I felt that we had a really good sample, but still in the whole overarching thing, it still is a small sample size. And the women did use a polysubstance use. But the more responsive the home environments were for developmental and emotional needs, the better outcomes we have for babies. And really just final thoughts for us to consider is that we do need to follow these babies up. Methamphetamine is a significant health concern, and we do need to consider developmental milestones and kind of put some money there. We do refer our children to a service here in Perth called Patches. James Fitzpatrick does an awful lot of work in the field of alcohol, fetal alcohol spectrum, but he also looks at developmental outcomes in these infants. So I'll just leave you with this summary that we really need early intervention and support, and that these women and families, they do really require and the best of what we can give. And we also continually advocate and provide a bit of a pathway of hope for them. These are my contact details. Please feel free to contact me, and I will stop speaking now because I'm sure we have a few questions.
Thank you, Angela. And yes, I'm sure we'll have questions. I know I've got a couple.
And sorry, I went a bit over.
Not at all. No, not at all. Thank you so much for your wonderful presentation, for sharing us your experiences through your PhD as well. I may have missed it. Smoking methamphetamines. Does your service encourage breastfeeding for those patients? I might have missed that, sorry.
So no, we didn't discourage it, because what we tried to do, and sometimes, you know, when we did discourage people from breastfeeding, they still breastfed anyway. So we kind of take that harm minimization and harm reduction with them. But if they smoked methamphetamine, no, we still allowed them, noting, of course, that if they're actively using, that they actually will be aware of the safety implications around it.
Yeah, no, that's fair enough. And sorry, look, Lucy has just put into the chat to please put your questions into the Q&A box or the chat box, and we will seek to address them. While we're doing that, have you had patients involved in any experimental treatments for methamphetamine dependence that have been pregnant? Most of the time they're excluded from these studies, but just I wondered if any studies that you'd had looked at that at all.
Yes, look, we work very closely with Next Step, which is an inpatient withdrawal unit here in Perth. But when it comes to methamphetamine, we do know that there's some drugs out there that people are kind of experimenting with, but we haven't done research in that space. But we do link into Next Step, and we're very keen. But people are often fearful when women are pregnant to be experimenting, and that's always that, you know, safe zone. And getting them involved.
Yes, and unfortunately, well, for obvious reasons, and it is usually a contraindication to most being involved in most studies, sadly. But it does sort of, you know, raise the point that methamphetamine dependence can affect pregnant women, and so perhaps some more work is needed, to look
Absolutely.
at potential options
Absolutely
that are
agree with you. Yeah. Yeah. 100%.
So yes, please jump on and pop your questions in the chat or the Q&A if you've got them. You've obviously done some research that extends, from what I picked up from your PhD, you'd followed up women up to around 18 months, is that right?
No, just 12.
Just 12.
Just
It was
12
just,
months.
I thought the
Yeah.
Griffith might have been at 18 months, sorry, so that's why.
Yeah. No.
Is there any, cohort studies are always challenging to organize, but is there any advances on trying to capture this cohort of both mother and child at 5 or 10 years?
I would love that, but it's kind of like getting, and really it's trying to, Carers WA here in Perth wanted me to have a look at a study to follow children up across the lifespan. So I kind of was trying to link into them and kind of trying to, because the parameters have to be really clear when you're starting to look at research in this field. But they haven't got back to me. So I think it became a bit, sometimes it becomes a bit overwhelming because there's children that are in care that, and also in foster care and foster families. I gave a talk recently, and because they see a lot of the aspects of developmental issues with the children that they have in their care across the lifespan. But no, we do need to do that.
And I'm just sorry, just quickly to pivot sideways for just a moment. Apparently, the chat was disabled, so please put your questions in the Q&A box rather than the chat. That might explain why. But we've already had one thanks from Florence, who's one of our who's over at NCCRED, who to say thanks for the presentation and appreciate your holistic approach. I just to come back to the what we were talking about. I guess there's a lot been made of the first 1,000 days initiative and so forth. So I would have thought it ties in nicely with that initiative. It's a bit of a, I guess it's yes. Well, it would be good to capture these children at that time point. Hopefully even later.
Absolutely. Yes. Let me know if there's people are keen. No, but really perinatal mental health in that first 1,000 days, it is absolutely crucial. I do think that early engagement into care, into antenatal care, and the more services and support we put in around women. And we have, as I say, we have had some really good successes with women stopping. And, even at the 12 months, some of them actually hadn't used, and they had been reunified with their baby. So that was a really good thing to see. And I think the more supports we can put in, we'll see changes, because that mother-baby bond is also critical, but also it's that long-term effect across that lifespan for the baby that we always have to consider and be aware of. But sadly, I'm going to have to drop out soon because I've got a workshop starting in a minute, and I'm really sorry to do this. But
no, not at all.
I'm more than happy for people to make contact with me, or if there's anything, you've got the PowerPoint available, and yeah, I'd really want to thank you all for listening.
No, thank you for presenting, and look, apologies to Erin, whose question we won't have time for.
That's okay. Yep.
Feel free to email Angela, and we will thank you again for your time. And just a reminder to everybody online that next week we will have Professor Kate Conograve and Tegan Weatherall looking at alcohol use in Aboriginal and Torres Strait Islander communities. So please
thank you
next week, and thanks again, Angela.
Bye.
Bye.
Thanks, Angela.